This approach is a needle-based ablation, and it's basically where we identify an area of prostate that needs to be treated with ablation, bracket that area with needles, and then between the needles, we deliver high voltage or high electricity. And what that does is that creates nanopores in the cell and kills the prostate tissue itself. But doing this, it's non-thermal. So surrounding tissues, structures, extracellular matrix, etc., is really unaffected by this. So it's a really unique way of killing prostate cancer while really trying to and essentially preserving kind of the surrounding tissues and minimizing side effects from it. It's, the way I explain it to patients, it's almost like taking a carton of eggs and kind of breaking the eggs with the voltage, but keeping the carton intact. So that's kind of the way I look at it. Um, and we've been using it here for about ever since I came to Cornell, so probably about 8 or 9 years ago. And we have lots of options available to us, HIFU, cryoablation, IRE. And I've kind of gravitated towards IRE for a couple reasons. One is you can kind of treat throughout the prostate. So you can treat anterior, you can treat posterior, you can treat apical lesions, whereas both cryo and HIFU have limitations with each of those spots. For example, HIFU has a hard time treating anterior lesions, and you're kind of limited by prostate size. Whereas cryoablation, particularly if you're trying to preserve potency, is limited with posterior lesions from that perspective. So the advantages of focal therapy or IRE specifically, if we're talking about standard of care treatment, such as radiation or surgery versus focal therapy, then the benefits of focal therapy really are minimized side effects, meaning less impact on sexual urinary function or bowel toxicity if you include radiation therapy. Um, but that has to be taken into context with the fact that there's some limits to oncologic efficacy with focal therapy. So patients really have to be really uniquely selected to be good candidates for focal therapy. And unfortunately, not all patients who come see us are good candidates just because of the basis that most prostate cancer is multifocal. For the patient that has an MRI lesion that has grade group 2 or grade group 3 prostate cancer, that's kind of the ideal patient for focal therapy. And in those patients, if they understand that the trade-off is decreased oncologic efficacy with kind of an improved quality of life, then that's something that we make a decision together. Usually when I'm treating patients for focal therapy, I really try to either have them involved with a registry that we have or some clinical trial because I think it's really important to um, really offer these patients like a realistic approach to managing their disease with focal therapy.